we're really excited about having Dr. Sue Borson today as our distinguished speaker. She is a professor of clinical family medicine at the University of Southern California and professor emerita at the University of Washington, where she developed its Memory Disorders Clinic and led the ADRC's recruitment efforts. Sue's work focuses on strategies for improving dementia detection and care delivery, caregiver self-efficacy, and the use of health system data to improve dementia care planning. She co-leads the CDC-funded BOLD Center on Early Detection of Dementia at New York University Langone and the Southern California Dementia Care Improvement Network. And Sue's work is guided by the continuing need to translate specialized knowledge of dementia education, detection, diagnosis, and care into practical, clinically meaningful, and effective tools to improve systems of care. She consults widely with healthcare organizations working to become dementia capable and seeks to integrate clinical, community, and public health perspectives into a unified framework for a more dementia-friendly society. We're so excited you're here today, Sue, helping us be more dementia-friendly here in Nevada. So with that, thank you again for being here. I'm going to go ahead and hand the virtual mic off to you. You should have screen sharing permissions if you'd like to pull up your slides.
Okay, so I need that introduction sounds like an awful lot of work. And my talk today it has a lot of stuff in it. So I've broken it out into let's see. So we can stop at various points. I built in some stops so we can have some pause and talk about things if you like. So let's take it and see how we go. Okay, so what are we? I'd be remiss if I didn't talk about what the BOLD Public Health Center of Excellence is on early detection of dementia. Briefly, it is one of 3 public health centers of excellence that relate to dementia that have national reach. Ours on early detection is bracketed on one side with the Center on Risk Reduction, which has a lot to do with lifestyle change to protect the brain and other related topics. And on the opposite side is dementia caregiving, the Center of Excellence on Dementia Caregiving. So each of these 3 centers has its own focus. The focus of my center is on early detection. And you'll learn something about that as I go through these slides. These centers have been funded by the Centers for Disease Control, and as you all know, the CDC has lost a lot of funding and a lot of staff, and we are currently in a 1-year extension on our project. Our project was due to expire at the end of September, pending new applications for another round of 5 years, but that opportunity never came up because CDC has been gutted. As a result, the government has given us another extra year of funding while they figure out what they're going to do about this. Why the government needs to do something about this federally is that there is a federal law that mandates the development of a public health approach for the United States that addresses dementia. That is the BOLD Act. It's a federal law, and funding has been allocated consistently by Congress for this. But at this point, we're kind of in a holding pattern, trying to use our 6th year to consolidate the work that we have been doing for the last 5. So our major goals here are to disseminate ways to improve detection, using the mechanism of co-creating solutions with partners. And we also seek to promote change within organizations. And you'll hear more about, well, what organizations as I talk. So let's talk about what we really mean. So we want to be clear, and I know that some of you almost certainly have some questions about, well, what are we really talking about? Are we talking about Alzheimer's? Are we talking about dementia? Are we talking about age-related cognitive decline? What is it that we mean? So dementia is a decline in cognitive function serious enough to impair everyday life. End of story. That is dementia. Says nothing about the cause, says nothing about the outlook, says nothing about the severity, other than it's bad enough that people need help to get through their day to day. They cannot live alone without somebody giving them help. Okay. So close family and friends may fill the gaps. And people with dementia may know they have a problem, as you know, or they may be unaware that they have a problem. So, what, so here, I want to share with you what our center uses as a, a kind of common sense way of thinking about dementia. I'm trying to get rid of all these other things that are in the way of my slides for me. So, oh, don't do that. I'm sorry about this. It's just, there we go. Okay. So here's a common sense way of thinking about dementia. If you look at the lavender and purple bubbles, those are the symptoms that you're all very aware of because you're all dementia friends. You've all been trained, you have understanding about this, and most, if not all of you, have personal experience dealing with people in your family or among your friends who have experienced this type of problem. So what you may not recognize is that dementia is the single most disabling condition of older people. You know, when you think about it, if our brains work well, we can do without a lot of other parts of our body working well. But if our brains don't work well, it doesn't matter how well everything else works because we're going to get stuck. So why does early detection matter in the first place? I like to show this slide, which I think is probably pretty hard to understand without some coaching. And so here's the coaching. Take a look at the top level, the top graph. That's hospitalizations. The bottom graph is outpatient clinic visits. Okay. Looking at the top graph, you can see that there's this sharp peak. And it's also, you see the same sharp peak in the outpatient visits. What is this graph telling us? It's telling us about when people first get a diagnosis of dementia. People mostly get their initial diagnosis of dementia when they are in a crisis. And that crisis is manifested by being hospitalized for a medical problem or an injury, or having extra outpatient visits because things are going badly with a person's health. This is the opposite of early detection. This is crisis-driven detection, and most of this accounts for why dementia is diagnosed at moderate and severe stages rather than at early stages. So it's helpful to know, and you can teach this in whatever you're doing with your dementia friends' efforts. Dementia increases the rate of preventable hospitalizations. I won't go through the numbers here. I'll just say that 78% more preventable hospitalizations are happening in people with dementia than people without dementia of the same age and illness profile. So dementia itself is upping the rate of preventable hospitalizations, things that go wrong that could have been managed at home or with outpatient care if they were detected and managed early. Okay. Well, why do we have such a problem with early detection? And this slide, you're meant to look at it and say, OMG, what am I seeing here? What you're seeing here is the rate of other diseases that are present in people with dementia. This was a group of 3,500 or so people with a diagnosis of dementia. And what you can see is there's a high prevalence of HBP. What is that? High blood pressure, hypertension. There's quite a lot of lung disease. There's a lot of stroke. There's a lot of diabetes, coronary heart disease, heart failure, arrhythmias like atrial fibrillation, poor vision, cancer, depression, osteoarthritis. So this is the profile of dementia in primary care clinics. People with dementia have lots of other conditions. And that makes it hard for anybody to focus on dementia as a part of the issue. So turning to why early detection can matter, it's really, think about it. There's treatments for dementia that are focused on the brain. There's management for patients and family, which is focused on combining health and social care to improve quality of life. And then there's kind of secondary and tertiary preventive interventions. Once dementia has already been diagnosed, then what do we need to do to help people avoid crises and manage quality of life to the maximum possible extent? So it's important for those reasons, but it's also important because detecting cognitive impairment at milder stages allows time for people to adjust and plan. People with mild cognitive impairment or mild Alzheimer's can often help plan their own care. But with over half diagnosed at moderate and severe stages, that's a problem because most people at those stages have enough trouble understanding how to think about themselves and their future and their current situation to be able to contribute very much to their own care planning, unless the decision is really simple. Like, will you take this pill for high blood pressure? Or do you want to have surgery to remove an early cancer in your colon? It's possible for people at moderate stages to still have some opinions about that and help. But in terms of really large scale thinking about how to improve their lives and manage their lives over time, you have to reach people at much earlier stages of dementia in order to include them in their own future care planning. So why don't we do this? Why don't we do this routinely? Well, there are a lot of reasons. One is fear. Sometimes people translate fear into stigma, but I prefer the term fear. People are afraid. Doctors are afraid of offending their patient. Doctors are afraid of feeling stupid. Patients are afraid of feeling stupid. Nobody understands what's supposed to happen next. Maybe I don't know enough to even ask a question, uh, and so on and so forth. But down at the bottom, there is no required quality measure for dementia detection or care. Um, there, Medicare doesn't require anything to be done about dementia. It creates opportunities, but it doesn't require it. So people, where we start with this, if we want to move toward earlier detection, is we have to start with the people who are living the problem in silence. Because affected people often know there's something wrong. Families see something, but they don't know what it is, how to put it together. Care partners lack support, and that sets the stage for the avoidable crises that are the usual way that people with dementia get diagnosed in the first place. We want to avoid those crises. So why does it matter more now than it did? I've been in this field now trying to encourage and promote early detection for, gosh, it's been almost 30 years. Um, why does it matter more now than it used to matter? Well, because we have better understanding and because we can do more than we could do 30 years ago. Getting a diagnosis opens the door to better care. So especially for the kind of work that you do as Dementia Friends, you can be part of the initiating the journey in your community toward agency. That means taking an active approach to understanding, supporting, and planning around dementia. You can help organize care partnership networks to sustain health and well-being. And you can, where you feel ready to do that and prepared for it, you can also teach about some of the new treatments and new opportunities that people might be able to consider. Things have really changed. So we now divide dementia into the clinical syndrome on the left. What do we see in actual people? And the underlying biology in the right-hand column. So everything we've been talking about so far today is the clinical syndrome. patterns of progression and special features of individual dementia types also. We're getting better at defining the earliest stages of decline thanks to developments in technology. So that means that we can do all kinds of tests to define stage of cognitive change, the type of cognitive change, what other kinds of things are going wrong with the person, such as difficulty with mobility and Lewy body disease or vascular disease, just as one example. But now what we're able to do, especially thanks to advances in technology, is we can now identify Alzheimer's disease biology, not just the clinical syndrome, but the underlying biology, and even do so in the earliest stages, and sometimes before there are any symptoms at all. So here we're talking about advanced brain imaging, such as PET scanning, and we're talking about blood-based biomarkers that are specific for different brain processes. These are all within the last 5 years. We've seen a radical change in the way we think about it. Clinical syndrome, what we see in people, and underlying biology, the cause of those changes. So I want to stop at this moment and give people an opportunity to comment. If there's anything you'd like to say before we move on to the next section, just go ahead and speak. And maybe our host can orchestrate that and let me know. There is a lot of science that backs up your own experience. So, and the science splits into three patterns. The first pattern is we've known for decades that there are families that have quite a few affected members, either across a single generation, such as a group of siblings who all develop dementia, 4 or 5 of them in the same generation, but then also vertically, grandpa, dad, son, mom, daughter. It doesn't go, by the way, by sex or gender, but it does go by genetic risk. And so let's talk a moment about that genetic risk. There is one major genetic risk factor that is recognized as conferring high risk for ultimate development of Alzheimer's disease. Not all kinds of dementia, but the form that we know as Alzheimer's disease with its own particular biology, okay? Alzheimer biology. The gene that increases risk to a very high degree is called apolipoprotein E4. So what this is apolipoprotein is a protein that carries cholesterol in the blood. It has a lot of other roles, and it greatly increases if you have the variant of apolipoprotein E that we call E4. There's 1, 2, 3, and 4. If you've got one copy of E4, your risk for developing Alzheimer's disease in later life goes up substantially. If you have 2 copies, which is the most you can have, of E4, then you're almost guaranteed to get Alzheimer's disease. Not everybody, but almost everybody. With 2 copies of E4, if they live long enough, they'll develop Alzheimer's disease. The second thing that E4 does is it accelerates the onset of Alzheimer's disease. In other words, people in families that have E4 tend to develop Alzheimer's at younger ages. Not super young. We're talking about 60s. We're not talking about 20s or 30s or 40s. Okay, but 60s instead of 80s. Just one additional point is that there are, as genetic research becomes much more sophisticated, much more study is done with new populations. We're learning about a whole raft of other kinds of genes that either play a facilitating role toward developing Alzheimer's disease or a discouraging role. In other words, they may limit your risk of Alzheimer's. So there are protective genes that are being discovered also. So this quickly has become really, really complicated. But the main effect remains the effect of apolipoprotein E4 as a late onset Alzheimer disease risk. Okay? Yes, I mean there's good science about this. The most common pathology in the brain of older people who have dementia, people in their late 70s, 80s, 90s, is a mixed form. Okay. So, and the mixing can be Alzheimer's and vascular, or it can be Alzheimer's and Lewy body. Rarely it's Alzheimer's and frontotemporal. It's mostly Alzheimer's with a little Lewy body and a little vascular.
Okay.
And the mechanisms that are underlying all this and how they work together to produce dementia is, I mean, that's very, very active kind of research going on today.
Okay.
For people who develop Alzheimer's at a young age, for example, my youngest patient with Alzheimer's was 28 years old when she was diagnosed. She had pure Alzheimer's. She didn't have anything else. But most people, the average person with dementia is someone in their 80s, and with several different comorbid conditions, usually some vascular disease and maybe a little diabetes, some hypertension, and so on. Maybe some heart disease, maybe a little lung disease. That person is likely to have different mechanisms, all contributing to the state of the brain. So that's the quick answer to your question. I think we should move on at this point, and any other questions we can get to later on. Okay, so what do we think about advancing early detection? And I'm not going to spend a lot of time on this, but I do want to speak directly to the role of dementia friends. Dementia friends have not historically been part of the early detection framework. But at the national level, with Dementia Friendly America, there's been quite a bit of interest in extending how dementia-friendly training could make it easier for dementia friends to assist in the process of talking about early detection and perhaps even doing some of that early detection work in the community. So the way we think about early detection now is that it really depends on where you sit, what your role is, determines what you're able to do, what kind of method you might use, what your strategy would be, and how you work with others. So what has been developing in this space is it used to be that a doctor was needed to test people. Now we know that medical assistants can test people, community health workers can test people if they're part of a care pathway. We know how to train people in identifying dementia. We're working currently on a curriculum for RNs. RNs don't have to have any dementia care training, but we have a curriculum to help them learn. How about a brain health navigator? Well, that's a non-clinical person who can be brought into a clinical setting to help out with some of this work. So the initial stages don't have to be done by a doctor at all. But what that then raises the question of, well, who do you screen? Are you screening a person who has a problem, or are you screening a population, a whole group of people? And I'm not going to linger on this because I think that I don't want us to get too bogged down in details with this. I'm happy to talk about it, but we as a center take these two separate kind of buckets of ways of thinking about it. That we screen individuals when someone brings up a concern about their mental function or about somebody else's mental function. And what do? Well, we screen for cognitive impairment using cognitive tests, or we ask somebody else about the functional abilities of the person about whom there is a concern. So that's the first way that you screen individuals. Do a cognitive test, do a functional scale. Is it affecting them in everyday life? The third aspect of screening of individuals that is not yet implemented in reality, but probably will be in the future, are tests of biological risk. Now, remember, we just talked about apolipoprotein E4, the major gene contributing to risk for onset of Alzheimer's disease in late life. Well, it's very easy to do ApoE4 genotyping now. We could do genotyping in everybody in your county, okay? If we wanted to, and people wanted it done, and there were money to do it. It is no longer, it's not difficult. We could get a distribution of apolipoprotein genotypes across a population of any size. But remember, apolipoprotein E4 is not an indicator of cognition or of current state. It is a measure of a risk factor for a future state. Okay? It's also, we could do the same thing with blood-based biomarkers. Blood-based biomarkers can pick up degeneration of the brain from a number of different causes. And the ones that we know about most right now are those that pick up Alzheimer pathology in the brain, because those molecules leak into the bloodstream where we can measure them. That's a blood-based biomarker. Comes into the blood through leakage from the brain. Okay. Now, what about screening a population? Why would we ever want to do that? Well, we might want to find groups at risk who may benefit from further evaluation, okay? And we do this especially in healthcare systems where a lot of people are being cared for, and we want to be able to find people who are at higher risk than average for developing dementia so that we can intervene early. And who are the people at higher risk? Well, certainly the older you are, the more your risk. Then there are other indicators too of higher risk. People who use a lot of emergency or hospital care or urgent care, they may be a high risk population for undiagnosed dementia. People who are experiencing social disadvantage, especially low education and low income groups. And then there are some known medical risk groups: smokers, people with heart disease and diabetes, hypertension, multiple chronic conditions. So in a healthcare system, we might want to screen the whole population using data that comes from the system itself, not data from an individual person that we test, but these kind of risk indicators that you can pick up in a large data set. So in working with individuals, detection starts with a conversation. That's really where it always has to start. Focusing on the person and leading with listening are the major skills that you need, and that is what Dementia Friends learn. And so you're ready, you're ready to think about it and think of because that's your training. Your training is in having conversations with people, and making them feel welcome and understanding what their concerns are. So focus on the person and lead with listening. And then as quickly as you can, include somebody else if there is a concern. And ask that other person if it's okay to find out something from their perspective. Are they a caregiver? What do they do to help? Do you think the person needs help? Ask the person if the person thinks they could benefit from some help and whether they're getting any. The common question is, do you need help managing your medications? Right? Okay. So conversation is really the launching point for better care for people. It might surprise you to know that many, or probably even most people with dementia, don't really have a care plan. And those who do may not know that they do. So what is a care plan? A care plan is a proactive plan that starts with key evaluations. You detect a problem, then you do some other evaluations, then you come up with a diagnosis, and assess the needs of the person and the people in their immediate network. And then you think about how to plan ahead for them now and how to anticipate possible future risk. That's a care plan. And some of the language that we use are, let's talk about where you live and what you can do to stay healthy. Let's talk about doing more things you enjoy. Are there things you'd like help with or need help with? What's most important to you to stay healthy? Whatever that is going to be good for your brain. And finally, we can do a lot to help you feel better and able to do more of what matters to you. This is an activist approach to care planning that I would dearly love before I am done with this life. I'd love to see more of this happening in healthcare and community settings. How do we even think about it? Well, this is the way I think about it. I call it 6 domains of health. So at the center, you can see there's a care plan. And you can see that there are 6 domains: cognitive health, emotional and behavioral health. And by the way, that would include loneliness, sense of disconnection. The third is physical health and functioning. Are you frail? Do you fall? How strong are you? How's your balance? What are your medical problems? What medications do you need to take? The next domain, domain 4, is care partner. Who's your main care partner? What do they need? How are you doing as a care partner? Are there any things that you need help or support with? The 5th domain is health-related social needs. Those are the social drivers of health, which mostly center on poverty, by the way. You know, it's economic disadvantage and social disadvantage that we're talking about here. And then finally, the care delivery framework. And that one is where we get stuck. We're pretty good at evaluating all the other domains: cognitive health and function, emotional and behavioral health, physical health and function, what care partners can do, need to do, and what they need help with, and health-related social needs. We can do all those evaluations. Where we fall down is we don't know how to evaluate the care delivery framework, except to say, it's not very good. It's not very well integrated. And we'll come back to that. So these are the 6 domains of health. And this is a way that we like to teach doctors and nurses and anyone else who's interested how to think about what a comprehensive care plan needs to engage. It's these domains. Okay, when we start to think about the health system organization and working with populations, then we have to start thinking about what are the organizations that are playing a role here. So there are really 3. There's the healthcare organizations, social care organizations, and public health departments. All of them have to be working together for us to do better at the level of population health. So this is a picture of the annual wellness visit. I'm not going to go into detail. All these slides will be made available to anyone who wants them, by the way. Our host can send them out. And if you have questions, maybe I'll stop right here and just ask if anyone has comments or questions specifically about Medicare's annual wellness visit. And again, I rely on the host to let me know if there are questions. Maybe I could just ask if anybody in attendance today has actually had an annual wellness visit themselves.
I
Yes.
have,
Tom
I
and
have,
I have.
Okay. And did you have a cognitive test during that annual wellness visit?
Yes, we did.
Okay.
Yes.
Okay. And did you get a care plan as a result of it? As a result of the overall wellness visit? Not just the cognitive assessment, but yeah. Did you get a care plan?
Not from the doctor's office.
Not from the doctor's office? Is that what, did I hear you right?
Correct.
Okay, so it is the doctor's office who is supposed to create this care plan for you and share it with you. And your experience is not at all unique. Health systems have varied an awful lot in how they do the wellness visit and how they communicate a care plan to individuals who've received a wellness visit. That's an area where we need to get more work, do more work to improve that quality. But thanks for sharing. Okay, so what have different groups done to try to improve early detection? So a part of the early detection problem is encouraging people not to be afraid, right? To do what you did, Peggy, which is say, I'm going to tackle this thing. I want to know what my current state is. I want to know the state of my health and what I can do to protect my health. If everybody felt that way, we would be doing a much better job at picking up dementia early when we could most likely do more about it to help. So this whole early detection piece began in a public health department in Wisconsin with a visionary woman named Kristen Felton, who just started, she said, we ought to be screening people in our public health department for dementia. It's an important problem. And that started way back even before 2010. And what's happened since then is that the whole state of Wisconsin has become much more attuned to dementia and developed a whole host of resources. So there are now, as of 2023, there are 70 dementia care specialists working in aging and disability resource centers. Okay. And as of 2021, the dementia care specialist program became a state budget line item. So training people how to do counseling and care coordination of people with people who have dementia. And you see that prominently featured on this slide is dementia-friendly communities, which has been one of the ways that this program has been spread across the state. It's through dementia-friendly communities. And one of my favorite programs, the memory cafes. This is so one of my favorite programs. I've been involved in starting several of those in different cities, and boy, I love them. Okay, so here's another example of how early detection can be promoted, and this one deals with tribal communities. So what we know is that Indigenous Americans are disproportionately affected by dementia. Most of the effect, if not all of it, is probably accounted for by social disadvantage. There may be some elements that are genetic, but what we know about this is that most racial and ethnic differences in dementia rates have to do with social factors, not with race. So where we look at possible biological contributions to these differences, we look at genetic ancestry. And this type of work with different ancestral populations in Africa, Asia, the Americas, and elsewhere have potential to show us not only about genetic risk for developing dementia, but also protective genetic factors and ways in which genes might interact with environmental circumstances to change your risk, either for the better or for the worse. So back to Native Americans. Indigenous Americans there has not been a detection or diagnosis program in Indian country historically. So the goal has been to develop programs that are uniquely well suited for tribal communities and for the Indian Health Service. So the goal is to improve detection. In this particular study, the Indian Health Service Community Health Representative Minicog screening pilot, which has been going on now for over a year, is to improve detection by training community health workers to screen older adults with a very short tool. So far, the data haven't been fully released, but what we're finding is that the acceptability of this practice is good. People don't object, they like it. the tribal communities have done a pretty good job of adopting the protocol. And there is a need for continuing to improve on referrals from the detection step to getting people into an actual medical evaluation and care plan. So this program is still continuing on with a new cohort called the third cohort, just starting up. So this is another opportunity for us to address any questions or comments you might have.
Sue, I'm so glad you talked about the incredible example happening in Wisconsin, funding a dementia care specialist for every county in the state budget. I just want to let everyone know that there have been two bills in Nevada in the last two legislative sessions to fund at least one similar type of position in each of Nevada's counties, leveraging the state budget. And those bills have failed both times. Not because people didn't think that it was a great idea, but unfortunately, it failed in the money committee. Even though it was, in my opinion, maybe not the most proactive thinking in one of the fastest aging states in the country. But fortunately, Nevada Aging and Disability Services Division did secure a 3-year grant from the ACL to at least pilot 3 dementia care specialists, or what we call here in Nevada dementia support specialist positions in 3 geographic areas, Washoe County, Elko County, and Clark County. And so everyone here, if you want to spread the word, those dementia support specialists will be serving communities beginning this month. And we're at least grateful to the ACL and ADSD for piloting the idea. But I think that Wisconsin is a wonderful best practice example for a lot of states to follow. And I'm really grateful that you brought that to us here. Thanks for sharing.
Well, thanks for taking it further and making it real in your own state. So one of the changes that happened, I know you know this, Jennifer, but others may not, is that the dementia care specialist program then was rolled out as an educational program for aging and disability resource centers around the state. And that made it work because those aging and disability resource centers have a mandate of their own. And so to translate the what started in the public health department into these aging and disability resource centers allows for much greater reach. The other thing that happened in Wisconsin, which is now being replicated in various stages and steps in some other states, is the creation of a statewide network of clinics that are prepared to do diagnosis of dementia. So that happened in large part, I believe, through the leadership of the Alzheimer's Disease Research Center at the University of Wisconsin and affiliated programs. So they developed a training program for doctors that they then were able to spread to many different healthcare systems around the state. So it's not being spread through, say, United Healthcare or an insurance plan or a given hospital system, but through all takers. So many different kinds of healthcare delivery systems have now have clinicians who have been trained in a standardized way of doing a diagnosis of dementia and developing a care plan. And so this is a beautiful example of how an innovation in public health translates back into healthcare delivery with doctors and nurses and social workers taking care of patients and being paid to do it by insurance plans. So oftentimes we think about it the other way, that it's healthcare research that then we try to spread out into public health. Well, it works both ways, and Wisconsin shows how. So they have 40 different memory clinics arrayed around the state so that the dementia care specialists have somebody that they can refer to. Okay, so it isn't a perfect program, but it's a model for the rest of the country. California, New York, Georgia, and a few other states are doing something similar, but on a much smaller scale, like 8 clinics around. I think in California, we have 10 state-funded clinics for the entire state of California. There are, of course, many other places where you can get a dementia diagnosis and a care plan in California, but I'm talking about what's been state-funded as a public health initiative. Any other comments or questions before we move on?
Let's see. Feel free to unmute if you have a question or comment.
This is Kat. Can you hear me?
Yes.
Hi, Kat.
Hi. Thank you so much for this, Sue.
So in most of most of the programs that deal with non-clinical detection strategies, delivered by a community health worker or a public health worker, but not a clinician empowered to do a diagnosis. For most of those programs, the most that gets said is, we recommend that you speak to your doctor, take the results of your screening, make an appointment with your doctor and talk about the results. So the best practice for a non-clinical person who's just in a early detection screening role is to say, your screening result indicates that you might have some risk for having a problem. But there is no vetted language. There's no widely approved language for doing this. And for this reason, a number of organizations really discourage screening for dementia by anybody who is not in a clinical environment. For example, C3, the organization that is working very hard to establish a national standard for certification of community health workers. Their official position is that community health workers should not screen for dementia. They can do some education, they can do various things, but screening for dementia is not their job. And in fact, they say don't do it.
Mm-hmm.
On the other hand, the 3 centers, the early detection, risk reduction, and caregiving centers have all come together to produce an article on community health worker roles in dementia, and we take a different view. Our view is that if a community health worker is tied in with a clinical pathway and is trained and supervised in administering simple cognitive screens, there's no reason they can't. It's just that they need to be tied in with next steps. Doing a screening by itself is not a useful exercise. The only point of doing screening is to do something about it, right? And so there's controversy about who can and should be doing this, but where there's a well-developed, as in Kristen Felton's initial program, she picked the mini-cog as the screener, and that's what people got trained to use, and she got data about that, and they use the screening score to recommend people go see their doctor and talk about it, tell the doctor about what was found. This is all works in progress. There is no one way.
Right.
But the take home for everybody that I want you all to take home with you is that screening is useless if it isn't connected with a pathway to doing something about the screening result. Okay? And even if a screening result is normal and a person really has concerns about their memory or thinking, they need to have a harder test. They need to go see their doctor and have that harder test that will be more challenging. All right, so I know some of you have questions about biomarkers and new treatments. And what are we talking about here? So just to make sure everybody's on the same page, a blood-based biomarker is a molecule that you can sample out of the blood with special testing that tells you something about a person's, now here's a word for you, a fancy, 60 $4,000 word, pathobiology. Okay, what's that? Well, it's a biological condition conducive to disease states, right? So Alzheimer pathobiology involves amyloid and tau proteins and a whole bunch of other things, but those are the familiar ones. So a biomarker is simply a measure of something that indicates the presence, the probable presence of a disease state at the biological level, not necessarily at the clinical level. Remember the distinction between the clinical picture. Do you have a problem? Is it affecting your function? Can we measure it? Do you have difficulty with cognitive tasks? That's the clinical level. What does it look like? Do you have any other symptoms? And then the biology is, many of us walk around with Alzheimer biology in our brain, but we're perfectly normal cognitively. We function well. Many of us will never develop even mild cognitive impairment, let alone dementia, a more severe stage of cognitive decline. Many of us will never develop those conditions clinically in spite of having a positive biomarker test. This is a really important point. Biomarkers, whether they are PET scans or blood tests or any other kind of biological measure of a disease process, doesn't mean you have the clinical disorder. Really, really important point. Where we are today is that now we have some federally approved blood-based biomarker tests for Alzheimer's disease. And what they are picking up mostly is amyloid in the brain and various markers of degenerative changes in brain tissue. That's what we currently have as blood-based biomarkers. There's research going on to find similar blood-based biomarkers for other forms of dementia, Lewy body dementia, Parkinson dementia, vascular dementia, not so much. It's a kind of a different entity. And we already deal with vascular dementia in a somewhat different way than we deal with degenerative brain diseases like Alzheimer's and Lewy body and frontotemporal dementia. So this is an incredibly active line of research with dozens of papers, literally dozens of papers published in peer-reviewed journals every single week. That just gives you a hint about how much of an investment is being made in blood-based biomarkers and trying to show how well they work and who they work for, and when in the course of the development of a degenerative disease do they turn positive, and whether you can use the level to give you a hint about how bad is the clinical syndrome right now? Is it even clinical? Can you even find cognitive impairment now? But can you stage people with cognitive impairment into mild cognitive impairment, mild Alzheimer's, moderate Alzheimer's, severe Alzheimer's? Can you use a biomarker to tell how long a person will remain in their current stage of cognitive decline before they progress significantly? So you can see there's an enormous investment in blood-based biomarkers as kind of the hot thing. And there's lots of debate about whether or not they should be used in primary care settings or should they be limited to specialists. There's lots to talk about there, but this is kind of where the huge amount of development is happening, along with the development of new treatments. Okay. So what do we mean when we talk about new treatments or novel therapies? We're mostly talking about antibodies against amyloid in the brain. antibodies that are given mostly through a vein, an infusion through a vein, but one type can be given by injection under the skin. But most of this refers to intravenous treatment with antibodies that help to remove amyloid from the brain in people who have Alzheimer's disease, not other forms of dementia, just Alzheimer's. And they have now been shown to slow cognitive decline in early stage disease, meaning mild cognitive impairment, MCI, or very mild Alzheimer's dementia. There's a lot of argument about whether the amount of clinical benefit you get with these drugs is enough to be important. There's enough disagreement about the amount of clinical benefit so that the agency in the UK that decides on what drugs will be covered under national health insurance has decided that, to use a colloquialism, the juice isn't worth the squeeze. The benefit isn't big enough to justify a large national campaign to provide expensive treatments to people. In the US, these drugs are approved and Medicare pays, but not everybody gets access. So if there are questions and comments about that, we'll deal with those a bit later. Right now, only a small percentage of people who have Alzheimer's disease are eligible for treatment at all. It's only mild cognitive impairment due to Alzheimer's pathology and early Alzheimer type dementia. Certain medications and conditions will disqualify you. In most places, if you have, say, atrial fibrillation, well, that's not a contraindication, but taking a blood thinner is. And the reason for that is because these drugs in some people can cause hemorrhages in the brain. And so for safety's sake, people taking blood thinners for any other reason are advised not to take it and may not be acceptable in a treatment center. Earlier on, we talked about genetics and Alzheimer risk. Well, it turns out that ApoE4, the major risk factor genetically for late onset dementia, is also a predictor of the risk of side effects with anti-amyloid antibodies, most particularly brain swelling and hemorrhages within the brain. If people are ApoE4 positive, their risk of developing one of those complications with anti-amyloid antibodies goes way up. So there have been modifications in the way the treatment is given to try to accommodate for that, but it's kind of a red flag. So everybody who is considered for treatment with these drugs or participation in a clinical trial has to have ApoE4 genotyping, have to find out what their ApoE genotype is. And they may be advised or told they can't qualify or advised not to participate if they're E4 positive. Okay. All right, so that's the kind of biological situation. There is a lot of gap in the implementation of these therapies. It's mostly highly advantaged patient groups who can get these drugs. They're antibodies, but we refer to them as drugs or medications. And health systems have to make large adaptations in order to implement a program of treatment. Many health systems don't have the resources or the desire to do that. So treatment is concentrated in centers where there's a lot of expertise, often places that have done a lot of clinical trials, and in academic medical centers with strong memory clinics.
Sue, I was just gonna,
Yeah.
sorry, just a quick, we just have about 15 minutes left, so just wanted to bring your attention to that. Thank you.
I'm aware, yes. Did you have things that you wanted to do with those 15 minutes?
Well, we like to normally have some Q&A, but you've been interspersing it as well. So,
There's
yeah,
plenty of time. There will be
perfect.
plenty of time. We're nearly at the end.
Awesome. You're the best thing.
Okay. So there are a lot of other kinds of treatments based on many different theories and many different basic science discoveries that are likely to be helpful in the future and applicable across stages of cognitive decline. You know, the future looks fairly bright, but the future of treatments also depends on the future of lifestyle interventions to reduce overall population risk. Okay. So there was going to be, I knew there would be questions about interventions that require, that don't require pills or infusion therapies, but are non-pharmacological. So non-pharmacological interventions are the foundation of lifetime care after a diagnosis has been made. So the philosophy is whole person, whole family, need-based care. You give people what they need and you apply it to the person and the family according to what they need. I consider the major goal that we all have now to be what I call no crisis care. In other words, one of our major goals across all of our efforts is to reduce the likelihood that people with dementia will undergo a crisis, a healthcare crisis, a crisis of caregiving, a public health crisis, undue expenditures, impoverishment due to costs of care, etc. This philosophy can be implemented in many different settings, but we aren't ready for it yet. We have many impediments, and this is where, if I were going to be encouraging dementia-friendly communities to really build, it would be in this arena to help, continue the work to change the culture of care that in a way that will mitigate financial and service challenges that we have today. So if we all come together around a common goal, the goal I favor is no crisis care, but there can be many others. Most people would say quality of life. Trouble with quality of life is that I'm not sure that we know what that really means. And so, because it means different things to different people. So I think we need more than just a quality of life outcome. I think we need a way of bringing everyone together to ask the question, how can I contribute to reducing the likelihood that things are going to fall apart for this person with dementia and their family, this community with a high burden of dementia and their families, etc. So you're familiar with many of the kinds of things that people do to implement non-pharmacological care planning. These are 3 different systems, or 4 different systems here: REACH, care ecosystem, D-care, and healthy aging brain care. They're just 4 different ways of explaining or describing a comprehensive approach that involves usually a kind of care navigation and care support for patients and families, usually some kind of attempt to connect with healthcare delivery. Okay, so to try to bring together healthcare, medical care, with social care in the community. These are 4 different evidence-based interventions and what they are focused on. And then we come finally to the guide model. Now, some of you know about this, perhaps all of you know about this. This is a pilot program under the Centers for Medicare and Medicaid Innovation. It now has 330 sites that are currently operating this program. And it's an 8-year pilot. It's based on research evidence, much of it gathered through the programs that I just showed you on the last slide, plus some others. And the goal is to improve quality of life for patient and caregiver, reduce acute care use, that's hospital and emergency room, delay nursing home placement, improve medication management quality, and reduce the costs of care. This is what GUIDE is all about. And those of you who want to study it can get the slides and take a look at this graphic. So I'm coming close to the end here, and I'm going to show you a prototype of a dementia detection and care program that you can think about as implementable within a health system, where it's centered around getting a diagnosis of dementia and then getting care for dementia. Okay, so this is a graphic that we developed for one particular healthcare system, but it can apply across the board. Here are the key elements. It starts up above with age-friendly hospitals. So inpatient hospital systems are now required by Medicare to certify that they are practicing age-friendly hospital care. Medicare is requiring this as of this year, and there will probably, within a few years, there may be a penalty for hospitals that don't do it. Right now, it's just being implemented. People are trying to figure out how to do this in hospitals. The age-friendly 4Ms measures are what matters to the person, mentation, and that means cognition, mood, etc., behavior, mobility, that would include frailty and difficulty with ambulation and so on, and then medication management to avoid high-risk medications whenever possible. Okay, so this is not a dementia-specific program. It is an age-friendly system. Okay, so from hospital, we move now down to clinics, because hospitals and clinics interact with each other in a circle, don't they? Outpatient, inpatient, outpatient, outpatient to inpatient, inpatient to outpatient. So in the clinic, a usable program starts in primary care with concern and screening, and then moves on to some kind of supported evaluation that a doctor does not need to do, but will need to interpret. Okay, so a brain health navigator, a non-clinician, can do an initial assessment with or without digital support. Feed that information back to the primary care doctor, who then has to talk about it and interpret the results and determine what additional workup might be needed and whether or not a referral to a specialist is needed. Most of the time, referral to a specialist is not needed. For people who have unusual conditions, super early onset of dementia, certain clinical features that are not typical of Alzheimer's or vascular disease, those patients may need specialty care to get a diagnosis. And the other group that needs specialty care is the really complicated patient where a specialist really should be following the person because there's too much complexity for primary care. And finally, the third reason for specialty care is to get access where it's available to these newer technologies of biomedical treatment, such as amyloid therapies. Okay. So then people arrive at a diagnosis, and then they may join up with a guide program. If there is no guide program, there still needs to be a care plan that is focused on whole person care that incorporates dementia. Okay, so opportunities for collaboration and support. These are just examples of things that we've created in our center, a toolkit for health systems, a resource guide for community organizations and departments of health. These are coming soon, and then a decision tree for how to implement and sustain early detection. Okay, and that's it. We have some other products, such as patient provider worksheets that we developed together with CDC when CDC was operating. So how to prepare for a visit, how to talk to your doctor, what you should know. And then if your doctor has told you have dementia, what should you expect? What questions should you ask? Okay, these are all materials available through our center if anyone is interested. Okay, so that is where I'm going to stop. Anyone interested in seeing the rest can take a look at the slides at their leisure. I have two thoughts. The first thought is that the policy that there is a national policy around dementia screening, and that was developed by the U.S. Preventive Services Task Force, which is a federal body or it's a federal body that is charged with doing evaluations, scientific evaluations of healthcare practices. They do easy evaluations like the effectiveness of a particular antibiotic for a particular condition. And they do hard ones like should older adults be screened for cognitive impairment? Should all older adults be screened for cognitive impairment? That was the question they were charged with in their first report, which is now many years old. Their answer was no. There's no reason to think that screening everybody for cognitive impairment would have a net benefit in the population. We don't have evidence that it would help people. We also don't have evidence that it'll harm people. And because the U.S. Preventive Services Task Force is closely watched by health insurers, by including Medicare, they tend to follow what the task force says. And the task force has said, cognitive screeners can detect dementia. What we don't know is whether doing that is good for people if they don't have a reason for concern. Okay? So that's one side of the argument. The other side of the argument now comes up because now we have these new therapeutics and more things that we can do for people. And because people who have cognitive impairment may not complain about it, many do not. Many do not complain. I can tell you that we've done 3 studies. I've been involved in 3 studies, one of my own at Washington in primary care, and 2 of them in Minnesota, one at the VA and one at a different health system, Allina Health. And what we found is that when we offered cognitive screening to all older adults coming into primary care, everyone was offered an opportunity to be screened. At the University of Washington, 70% of people were screened. And in the other 2 studies that came several years later, only 4 to 10% refused. So there's this feeling that, maybe people want this, but we still have a long way to go. Now, there's another argument, and Medicare has realized that judgments about cognitive impairment as a result of the annual wellness visit are being done in a very haphazard way. Unsystematically, the fear is that a doc looks at a patient and the patient seems normal, so not going to do anything. That person's fine. Well, I'll tell you that one of the skeptics that I've been working with at my own institution, who happens to be the chairman of the Department of Internal Medicine, referred her patient who had a complaint for screening. The doctor thought the patient was perfectly normal. The screen indicated the person had early dementia. The doctor was shocked and said, well, now I understand why we're doing this. So Medicare is on the verge of requiring a validated cognitive screening tool within the wellness visit. But to my knowledge, they have not done this. It's not required now, but increasingly health systems that are doing more and more wellness visits are incorporating some kind of a cognitive screener. And I do have my own misgivings about it because there are such things as false positives, people who score abnormal who are not, and false negatives, people who score normal but are not. And that's the nature of all screening tests, just so you know. Screening tests are like that. And the only analogy that I can give you that might make some sense is, well, what about using a blood sugar test to screen for diabetes, right? Okay, Well, you can make similar mistakes in screening for diabetes if you think your patient is fasting, but they actually just had 3 donuts. Okay? And so you get a false positive with the person you thought was fasting, no breakfast, nothing to eat for 8 or 12 hours, but they had 3 donuts and their blood sugar shot up. Oh, diabetic. If you think they were fasting, you're going to make a mistake.
Mm.
So these are just characteristics of screening tests. So that I will leave you with that level of uncertainty. I know we're over time. If anybody has anything more, I'm happy to stick around for a minute or 2 or 3, if there's anything more.
Thank you so much, Sue. Thank you for your time, for sharing your expertise with us. This was an excellent presentation. We're really grateful. And thank you all so much for being here today, for joining us